Hello again, I'm Dr. Hung Vu, and our show is America's Healthcare Crisis. Tonight, we're going to continue with our discussion on the quality issue in medicine. And as promised, I have with me tonight a panel of 4 well-respected speakers working in our community as health providers, and I'd like to introduce them without any delay. Our first speaker is Pat Homestead. Pat has a master's degree in health administration, has been working with Kaiser Permanente for about 9 years, and recently has joined the team at O'Connor Hospital.
That's right.
Welcome to our show, Pat.
Thank you.
Thank you for being here.
My pleasure.
Our second speaker is Ramona Hodges. Ramona is a registered nurse and has been with O'Connor Hospital for many years now, and is an instrumental part of defining the quality issue at O'Connor Hospital. Welcome to our show.
Thank you.
Our third speaker is Dr. Joseph Zammuto. Dr. Zammuto is a osteopathic doctor. He has been in practice of family medicine in Fremont for many, many years now, and he's very popular in Fremont.
Well,
thank you for coming. Welcome to our show. How are you feeling tonight?
Excellent.
Good.
Excellent.
You just came back from a Caribbean cruise or something?
I was on a 7-day Caribbean cruise.
Oh, great,
Plenty
great.
of food, dancing, and fun.
Welcome to our show. Our first speaker is Dr. Richard Swanberg. Dr. Swanberg was in family practice in Mountain View for a number of years, and now he wears the second hat as medical director for a prestigious health plan called One Health Plan?
One Health Plan,
One
Great
Health Plan.
West Life.
Okay, welcome to our show, Dr. Swanberg.
Thank you.
Why don't you folks introduce yourself briefly to our audience as to what you are familiar with so that we can eventually listen to your opinions.
Okay. My name is Pat Homestead. I'm the Continuous Quality Improvement Coordinator at O'Connor Hospital. I've been there since May, and prior to that was the Quality Improvement Director for Kaiser Hospital in Redwood City, and I've been with Kaiser Northern California for the past 9 years in various roles related to the quality area. In my role at O'Connor right now, I'm responsible for working and coordinating with all of the performance improvement teams, the multidisciplinary teams that we have working in the medical center on various quality improvement projects. And I'm also actively working with the teams that are developing critical paths in the hospital. And those are my primary responsibilities, in addition to working with Ramona in the development and implementation of the performance improvement program for the hospital.
Would you mind define clinical paths again? I think we defined it in a previous show, but maybe you can repeat that and define clinical paths for us.
Oh, well, critical paths or clinical paths, or various names for them, are really a tool, a methodology used to define the ideal model of care that's given to a particular population of patients, for example, pneumonia patients or total hip replacement patients. And it would define for each of the disciplines that would treat that type of patient the ideal care that they would receive on each day of their hospital stay for each discipline, and could also even extend beyond the hospital stay to include care that they might receive as an outpatient prior to their admission, and then care after discharge. So
Sure.
it really depends on the path, whether or not it's confined only to the hospital stay, or if it's the whole continuum of care.
The idea is comparing different pathways and find out which one is these
Well,
more
the
cost-effective
teams
or
do
better.
look at pathways that have been developed in other hospitals, but then the team, the multidisciplinary team at O'Connor would decide what was appropriate from their perspective for our hospital, and then the team would agree as to what our particular pathway would be for that specific diagnosis or procedure that they were working on.
Okay, thank you. Ramona?
Well, let's see. I've been at O'Connor 33 years, and the majority of those have been in critical care. In fact, I opened the first critical care at O'Connor on the night shift. I was the night RN. And so I've seen a lot of changes over the years in clinical, in the inpatient care situations. I think over the years, I developed a lot of credibility with the clinicians there all the hospital team, the physicians, the administration, all the patient caregivers. And from that basis and my clinical background, I decided I wanted to try to make a difference in the quality management department, which I think I have, because when I first started there, we were in the auditing mode of quality, where you just audit a chart now and again and see what you find, and maybe, you know, it was pretty punitive. I think people found that it used to be very punitive. You were looking for trouble all of the time. But over the years, it's really, I believe I've been very instrumental in helping develop a real sound performance improvement program at O'Connor that is a lot less punitive, and I think geared a lot more toward looking at what constitutes quality from everybody's position, the physicians, the patients, the staff, the administration, the different third-party payers, and trying to define a performance improvement program and implement that in the hospital.
So far, have you had more agreements or disagreements among those different disciplines?
Well, I think in certain situations, everybody can agree what quality is, pretty basic, clinical situations especially. But when it comes to, I think when it comes to the consumer, to the patient, they have a much different idea of what constitutes quality than the healthcare team does. And I think if you talk to the different disciplines, they'll all define quality from a different base. I think that's probably our major task facing us right now, is to try to find a common mode to define what kind of quality, or what quality is in our institution. I have my ideas, Pat has her ideas, I'm sure the doctors have theirs, I know the patients have theirs. My mother's idea of quality, in fact, I just talked to her yesterday, she's, her idea of quality, she's 83 years old, and she lives in a small town near Stockton, and her idea of quality is not having to wait on the telephone, listening to a video saying listening to a voicemail, saying we're very happy to hear your call, but please hold on the line, you know, for 25 minutes. That's her idea of what healthcare quality is. She had to wait a half an hour on the telephone. So the perceptions are really different. I think that's our biggest challenge facing us in the future.
Yeah, is to find common denominators.
Exactly.
Dr. Zamora?
Well, I've been in family practice for 12 years now in the Fremont area, and I've been involved with Washington Hospital's medical staff committees. I'm past assistant chairman of family practice, past chairman of the ethics and peer review committee, past member of the URQA, which is the utilization review quality assurance committee, which is always going through different name changes. TQM now, which is total quality management, so the alphabet soup of medicine. On a statewide level, I've past president of the Osteopathic Physicians and Surgeons of California, which is the state osteopathic medical association. I am a past chairperson of the Mulliken IPA Mission Peak region. I am also a board member of the HealthGuard IPA in Fremont. So I've had a variety of hats dealing with patient care on a full-time basis, and then dealing with the politics as well as the business side of medicine.
Yeah, okay. Dr. Swanberg?
Like the previous speaker, I've also worn several hats. I've been in private practice of family medicine in El Camino Hospital in Mountain View for 13 years. I've served as president of the IPA of the Mountain View Family Practice Association called Coast Medical Clinic. I've been medical director for 2 years of MetLife Healthcare in Northern California, and the last 2 years I've been medical director of the for the state of California of Great West Life One Health Plan of California, overseeing the utilization review and quality assurance for 300,000 Californians. And I also have been involved in family physician activities as an officer of the California Academy of Family Physicians. And I too am concerned about quality, both from the physician's point of view as well as the payer's point of view, to see what we can do to define that in a little more exact terms.
Yeah, I believe that we have a critical need to have a dialogue or a three-way conversation among the three players: the providers, the patients, consumers, and the third-party payers, because we need to define the area where we can agree upon is basic what we call qualities, because we're still in the infancy episode for that kind of activity. Let's forget for a minute that you are nurses and doctors and care providers. Let's consider yourself consumers. Have you been sick recently? And let me tell me how you found your doctor and how you qualify his care for you.
Well, actually, I did have an occasion to visit a physician within the last couple of weeks, and there were good and bad things about the experience. I think, as Ramona was mentioning, when you're a busy person, access is one measure of patient satisfaction. I don't know if you'd call it quality per se, but to me that's an aspect of quality. And I had some difficulties with accessing my provider. It took me some time on the phone and some explaining and then explaining again what my need to see the doctor was. And so that was something.
So you talked to a screen person?
I talked to two screeners, two individuals that screened my call and wanted to know information about what my situation was. And then I was finally able to get an appointment. When I got to the physician's office, I had about a 25-minute wait. And I wasn't feeling very well at the time, so that was not a good perception. No one came out to give any explanation as to why there was a delay or that something had happened or that they knew that I was there. It just occurred. Then I was called into the physician's office, and when the physician came in, the physician didn't know why I was there. The physician had to ask me why I was there, and after having explained it twice, that was rather upsetting. But the clinical care was good. The issue was dealt with, it was resolved, and there was no problem with that. But the system didn't work well for me. It didn't support my being able to get the care I needed in a way that felt as though I was being acknowledged as a patient.
How long have you been under the care of this particular physician? Either a primary care physician or a specialist?
This was a primary care physician. This was the first time I had seen this person. And that really isn't a problem for me. I don't have a need necessarily to have one physician that I see all the time. But I felt that the system should have supported some continuity between the individuals that I dealt with, and they didn't seem as though they had talked or communicated with each other.
How did you pick him or her?
How did I what?
How do you pick your primary care physician? You just open a book and
it's the person that I was assigned that I could see first. And I'm sure that if I was a person that required a lot of care and was going on a regular basis for a particular condition, I would want to have someone that I knew and had a relationship with. But for most of my care, it's a one-time thing. I go in and I'm seen and it's dealt with, and so I don't care so much about the personal relationship, but I want it not to be I don't want to feel as though there are stumbling blocks there or impediments to me being able to get what I need.
So, I mean, that's kind of surprising to me, because I would personally choose my doctor much more carefully. You know, I'm not saying that, you know, that is not something that people do nowadays, but, you know, you pick a name of a doctor out of a book without ever knowing who he is, or nobody can recommends him or anything like that. Okay. So it seems like if there was a deficiency in the care that you just received was the communication process.
I think it was the system of care hadn't been well planned out and thought out from the patient's perspective. To say, when a patient enters our system, how are we going to ensure that their experience leads them to feel that they're being thought of in this process. It was more the convenience of the healthcare provider, I think, and the way in which it worked for that provider, rather than having thought out what will work best for our patient.
Yeah.
Because the clinical care was really equivocal. I mean, I expected when I went to the physician that the care would be adequate and that I would be taken care of, and I was.
How much time did the doctor spend with you?
About 5 minutes.
5 minutes. Anything that was enough for him to evaluate your situation?
No, I felt that I didn't feel rushed. I felt that the clinician spent enough time, did a good assessment, talked it over
Okay.
with me, so that really wasn't the
Okay.
issue.
Okay. Ramona?
Well, I haven't had any illnesses recently, and it seems like I grew up with my doctor. We've known each other a long time, so I don't know whether I'm a good one to ask about access or even perceptions about physicians. I'll tell you the one thing that would disturb me as a consumer would be if I had to change physicians. At this point, I've been going to this physician for many, many years. I feel he knows me. I think he cares about me. And I feel like he knows me well enough to know that if I call him with a complaint, that it's important, you know, that it's because I'm not often sick. And it would frighten me if I thought I had to change doctors. And that was another thing my mother said. Her idea of quality is being able to pick her own physician.
Yeah.
And I think it would worry me if I had to change at this late date because I've been going to him for 20 years. And or even my dentist. you
Yeah,
know.
that's exactly the point I was trying to make when I asked Pat. You know, I don't know how in 5 minutes you can really get to know a patient. You know, I mean, it takes 20 years. You know, I mean that to me is I mean the time is that can never be replaced. You know, I mean the continuity of care, and he knows you and he cares about you. Those are the two things that I heard that are very significant.
I think you're looking at the difference, though, perhaps in like an acute illness. People go to the emergency room, and they get seen by emergency room physicians, you know, for really not critical issues. A lot of ERs are being used these days in that mode. I mean, where they'll have, you know, a complaint of a stomach ache or an earache or a cold, and they'll go to the ER and they'll be perfectly satisfied with the care they receive by that physician in the 5 minutes they can see them. I think it depends on the situation. Personally, like I said, I'm not ill that often, and when I am ill, I'm really ill, and I want, you know, I want to be personally cared for as a person, and I know this physician does that.
Do you think insurance companies should pay for regular checkups and preventive medicine?
Do I think what?
Regular checkups and preventive medicine? You think insurance companies
Should pay?
pay for preventive medicine? I'm saying
Yes,
that
I do. I think that if the insurance companies paid for preventive medicine, they'd be paying less for acute care. I believe that wholeheartedly. Yes, I think it would
Okay.
encourage people
Yeah.
to
Because
go
the
get their.
time the doctor spend with you when you're not sick can be very, very helpful
Oh, I
in
think so.
evaluating you when you're
A
sick. isn't
baseline.
it? Okay. Zamuna?
Well, I had the opportunity to become a surgical patient in December of '94. I think the most important lesson that I learned is what it was to be a patient. I think the biggest issues that we as physicians sometimes don't acknowledge or don't accept is the vulnerability that you feel as being a patient,
Sure.
the whole emotional trauma that you go through in being a patient. I had a herniated lumbar disc that required surgery. So I had to decide on who's going to do the surgery. And I, as a physician, was fortunate enough because I had scrubbed a number of surgical cases, so it was easy for me to choose. But for someone, a patient who's not a physician, how difficult it is to know who to go to, and that's why
Yeah.
you rely on your primary care physician and the trust of their decision to say,
Yeah.
this is someone who's going to do their very best job, because I knew from firsthand experience what kind of care I was going to be giving. And obviously, even with knowing that, there's still that level of trust, that level of security, that level of personal need. And for me, the most difficult thing was the fear of anesthesia.
Sure.
Because being a type A individual like I am, even though I'm trying to be type B, is that willingness to give up control
Yeah.
and that fear of loss of control and the whole experience.
So did you go to the specialist directly, or did you call the surgeon directly?
I called the surgeon directly because I had already had the symptoms for a 3-week period, which were getting worse, and I knew clinically what was going on, and
Right.
things weren't responding the way that I
But
would have
normally,
liked them to.
do you or your family have a primary care physician that you go to?
I do have a primary care physician that I use, but in this case, for time issues,
Sure.
I just went
Sure.
straight to the specialist.
Yeah. Dr. Swanberg?
Well, I agree with the feelings of all 3 previous speakers. I've also been a patient in the past, but not recently. But I think one of the things from a medical director's point of view, one of the things we look at in terms of access is we get, as well as other health plans, what's called member satisfaction surveys, in which we look at the care given by the various primary care physicians throughout the state of California. We ask,
I'm asking you your personal experience with the healthcare system. Have you been sick recently?
no.
No.
I've
okay.
been,
How about
I've been
your
healthy,
How
fortunately.
about your family?
No, my family has been healthy too.
I see. Do you have
So-
a primary care physician?
Oh yes, I have a family
Okay.
physician that
Okay.
takes
How,
care of
how
my
did
family.
you find him? How did you pick him?
I knew him personally.
I see.
When he came to the community, I was his monitor
Good.
coming into El Camino Hospital, so I've checked him out thoroughly.
Yeah. Let me ask you something. You know, that's something that sort of fascinates me. When you choose your doctor, do you go more by his credentials or his practice experience? You understand what I'm saying? You know, a lot of people think that a board certified doctor from Harvard, you know, is what he wants. I mean, is that the case? A recent graduate from Harvard is what do you pick, or somebody who has practice experience?
I think what's most important from my perception is someone who can relate to you as an individual.
Sure.
I mean, I think it's valuable that they're trained at a appropriate medical school, you know, perhaps the United States, but a good training with a good residency is what we're looking for. But someone who can communicate and listen to what you're telling them is far more important than 17 degrees on the wall if he won't listen to what you're saying.
Right.
From the point of
Yeah.
view of a primary care physician who you want to speak to and
Yeah.
communicate with. I mean, one of the things that I felt most important in practice is someone that would give a continuity of care across a multi-year period, like you mentioned, of a 20-year period of
Yeah.
time,
Yeah.
is very valuable in terms of a relationship building situation.
Because, you know, I thought about the situation when, you know, a lot of people, every single physician I have met in this country thinks that he has come out of the best residency program, no matter where it is, you know. So a quality residency to me is a very vague concept, because everybody thinks that he has the best, you know. And also, I personally believe that there's such a dichotomy between academic medicine and community practice. In other words, in school, you learn, you're very pathology oriented, isn't it? And you are trained to diagnose and to treat diseases. And when you go to the community, like Dr. Zamiro, we talk about the fact that most of your patients are depressed. They don't have a heavy-duty brain tumor or meningitis, or is it another situation? What do you think? Out of 100 patients you see last month, how many of them had a significant life-threatening condition?
Probably less than 2% had life-threatening, but I think you hit the nail on the head when you said that the majority, and at least 50% of the patients I see day in and day out, have either depression as a major part of their problem or as an associated problem to their illness. I think one interesting question that I always ask my patients is, why did you pick me? Some of the answers will be because you are on my health plan. Some of the answers will be because my friend, my mother, my sister, someone recommended you. One was because you're close to work, close to home. So you get a variety of different answers as to why people come. And each of the personalities that presents usually has different needs. That's something that I'm trying to improve on, is being sensitive to the personal needs.
Go ahead.
Of those individual patients.
Yeah.
So that I know if they're coming to me for a physical problem, an emotional problem, or a combination of such. And sometimes someone just wants to know that they're fine, and they want the encouragement that they're doing the right things in their health.
Yeah, right.
Sometimes they're coming because they're so confused they don't know where to begin.
Yeah, that's what I really was very interested in hearing what you have to say, because I have had the same experience. In other words, I have seen many patients in my lifetime of practice. I've been practicing 25 years now. And most patients have a rather self-limited, stress-related conditions, at least in the atmosphere of primary care anyway. I think that we are running out of time. See how fast it is? We talk about a few things here, and anyway, we have a little more time, but I think that we can wrap up here. And this is our third show on the quality issue in medicine. And we have turned the table a little bit and asked our respected care providers to talk about their personal experiences, and I really appreciate their sharing with us that personal opinion about the care they have received. And I think that that to me is very insightful, because we want to know from their own opinion what they qualify for themselves and not for their patient necessarily is quality medical care. We're wrapping up this third show because we're running out of time. I'm Dr. Hưng Vu. Our show is America's Healthcare Crisis. This is the third segment of the quality issue in medicine. I'd like to invite you to continue to watch further shows on this important subject. Thank you for watching. Good night.
Do you love someone? Have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years?